Yes, I was working with Dr. Felipe Jain in his lab just across the street, working with dementia caregivers. So dementia caregivers experience a lot of depression and a lot of other things like anxiety and stress. And so we're really working to see if we can help decrease some of these levels in them. So I'm so grateful for the opportunity I had to work with Paulina, with Miranda, Maria, Dr. Felipe Jain, Liliana Ramirez Gomez is a neurologist, and multiple other interns. And yeah, the title of my project was App-Based Mentalizing Imagery Therapy and Caregiver Skills Interventions for Rumination, Loneliness, and Caregiver Burden in Family Caregivers of Persons with Dementia. So yeah, we were working with family members who were caring for a relative with dementia. So I'll describe a bit of what I did and then describe the study a bit, and then I'll go through some of the results. So initially I helped with recruitment for this study. I mailed hundreds and hundreds of letters, and then that resulted in phone screens where we called potential participants and screened them to see if they matched the criteria for the study. I also was involved in qualitative analysis. So this was involved reviewing the interview transcripts. So at the end of the study, the participants were interviewed, and then these interviews were transcribed. And then I did what we call coding, which is basically assigning labels. So if the participant talks for one paragraph about how the relationship with the family member that they were caring for was improved, then we would code that as an improvement in that relationship. And then if they mentioned the support groups or meditation practices, it was just like assigning labels to all those things. And then was data analysis. We gave the participants surveys at the baseline, post-group, and at the long-term follow-up. And then also did programming using R to look at the data. I was also involved with formatting some manuscripts and submitting them to various journals for publication. And so the question that I was wanting to answer is, will caregivers who receive mentalizing imagery therapy and caregiver skills through the app exhibit superiority on self-reported loneliness, rumination, and well-being measures relative to those receiving caregiver skills alone? And so I will be referring to either MIT and CS, or also referring to those as like a multi-component program, and then CS is just the caregiver burden. And as far as the app, so the Today tab at the top had a list of recommended modules for each day, as well as short questionnaires. And then this is the screenshot of the multi-component program. So the caregiver skills app would not have had the relaxation practices and the background tabs. So this is what the caregiver skills app would look like if you had clicked on the caregiver skills tab. This is looking at a few of the modules out of a total of 37 modules. So the modules are short writings with more information about things like the stages of dementia, exercises that the caregivers could do for brain health, and so on and so forth. And then with the relaxation practices, there were 7 of those. And so they involved things like stretching and breathing, nesting doll-like kind of meditation to get to know yourself better, as well as the perspective of others. And then there were also 30 background modules that gave more information on the different meditations, and if participants were having difficulties with a meditation, just helping them figure out how to continue. We also have a chat feature here, so the participants can message with each other, help if they're having issues with the app. They could reach out, and then there was always a helpfulness rating for the participants, so they could rate the helpfulness of each page that they were looking at. And I love here we have the home button where they could return home, and a bookmark where they could go to a previous page that they were looking at. So that's a brief overview of the app. And then now I want to define a few of the words that we use. So mentalizing imagery therapy is the therapy that we're offering. And mentalizing refers to understanding your own thoughts and feelings as well as those of others, and holding another person's heart and mind in your own heart and mind. So paying attention to both your needs and theirs. And then it also involves nurturing good relationships by keeping both perspectives in mind. So attending to needs after having looked at both perspectives. Imagery is basically visualization, so the ability to see. So using the imagination to gain different perspectives, trying to see things from either the patient's perspective or someone else's perspective. And then we're promoting mindfulness, which is the ability to regard yourself and others without negative judgment, being present in the moment, and then having the objective perspective of faults instead of ignoring them. So it's not putting things aside, but looking at them objectively without judgment. So then I had the opportunity to present a poster at Harvard Psychiatry Research Day with some of the results after we completed the study in February. And so I'll just go into each section a bit more deeply. So with the background, we see that family caregivers of persons living with dementia are vulnerable to experiencing psychological stress and depressive symptoms. There is a gap in knowledge on therapies to support the caregivers in reducing stress, caregiver burden and loneliness, all these things. And we aim to compare the effects of the multi-component 8-week program that included the caregiver skills, guided imagery, and mindfulness practices. We're comparing that with the caregiver skills only program. Methods: participants were divided into 2 groups with the multi-component program and the caregiver skills program. Information was delivered via the mobile app, and participants could join a optional 1-hour virtual group for the 8 weeks of the study. And we took measures, so gave the participants surveys for caregiver burden, rumination, loneliness, and multiple other measures at baseline, post-group, and the 24-week follow-up. And then the perceived stress, which was the primary outcome, we were looking for a change in perceived stress. Those measures were obtained at baseline and then every week for weeks 1 through 8. And we did longitudinal analysis with mixed linear models and R using the package NLME. So initially our results for perceived stress were not that promising. The p-values didn't seem to be statistically significant, but we noticed that there were about 30% of the values that were missing. And so once I wrap up the poster, I'll talk a bit more about some things that we have since been able to look at after I presented this poster in February. So these are some of the other measures: caregiver burden, rumination, and loneliness. We don't see a significant change in any of them except for rumination, where we see a significant change, but in both groups, and we were wanting to see a difference, preferably between the groups. A few of the demographics. So the caregivers in this study were 50 years of age or older, and so our average age was around 69. We had about 70% female and 80% white, along with a few people from other races. And then the average hours of caregiving duty per caregiver in the study was around 47 hours a week. And there was a lot of variation there, with a few caregivers only spending a few hours a week to others caregiving full-time. Our conclusions were that family dementia caregivers who received the multi-component program did not demonstrate significant reduction in perceived stress compared to those who received CS, which I will again talk about this once I'm done with the poster. As for the other outcomes of loneliness, caregiver burden, and rumination, there was no superiority for the multi-component program. Further analysis will address whether those who practice guided imagery regularly exhibited larger improvements. So we don't know whether all the participants who were in the multi-component program actually practice the guided imagery practices that we recommended. And then future studies will also aim to refine the multi-component program with AI methods to further increase its efficacy. So focusing more on specific caregivers and what their needs might be. So here, after noticing the missing values, we undertook a multiple imputation for the perceived stress using the package mice. So the participants were filling out these weekly surveys, but also daily surveys. And so we use those daily values for subjects who had no more than 3 missing perceived stress values weekly. And we found that when we imputed this information, that there was a significant decrease in the group that did the caregiver skills and MIT versus those who just were in the caregiver skills. So we have a p-value of 0.01, which means that there was a significant difference between the two groups. And since the measures that I was looking at, the caregiver burden, rumination, and loneliness didn't show significant changes by group, I decided to continue with further analysis of the baseline data, still focusing on some of those measures. So I was looking for correlations between caregiver burden and some of the other variables that we were looking at. We see that participants who score high in loneliness also have high scores in caregiver burden, and same with perceived stress and with rumination. So there was multiple correlations that we found, but I just have these few up to give you an idea. And a lot of these correlations have been observed in previous studies, so I wasn't going to look much more into what those correlations were, but I started looking for other correlations between the demographic and clinical variables to see if there was anything noteworthy there. This is a heat map of some of the significant correlations. So down here we have demographic variables, and this is not all of them, just some that had significant correlations. It includes the demographic variables include things like race, age, whether they're working full-time, part-time, how they're related to the family member that they're caring for, different things like that, as well as the type of dementia that their family member has. And then with the clinical variables, we were looking at a whole bunch of things, but here we have a measure for rumination. QIDS is a depression measure. ISI is an insomnia measure, and CBS is the caregiver burden. So that's just a few of the measures that we were looking at. And what we saw was that of the demographic variables, the one that was correlated to a lot of the clinical variables that we were interested in was sex. So being female is correlated with having a higher caregiver burden and a number of the other measures. So there's higher scores for the female. So I decided to see if there was any mediation between any of these variables and sex and caregiver burden. So we did some mediation analysis, and that is where we tried to find mechanisms that underlie or identify mechanisms that identify and explain the mechanism or process that underlies the relationship. So we're seeing a relationship between sex and caregiver burden. What are the variables that could be mediating that relationship? And this is what we found. We found that sex is a predictor of caregiver burden. So being female is a predictor of caregiver burden, and being female is also associated with higher levels of rumination, and that high levels of rumination are associated with higher levels of caregiver burden scores. So when we put sex and rumination together, then we see so that's here with this measure, we see that rumination reduces the strength of the sex effect on caregiver burden, showing that it mediates the relationship. So here we see that there is a significant relationship between being female and having caregiver burden, but then when we add rumination to it, then it's no longer statistically significant. So it needs to be below 0.05 for it to be statistically significant, which indicates that that rumination is a mediator. So using this information, we can try to find treatment methods that focus on reducing rumination and see if we can help reduce caregiver burden. And so I could have done this analysis with a few more of the variables, but didn't have time now with wrapping everything up. But that was something that I was really interested in, looking more into some of these other variables. So just as a summary, I talked about a lot of the different things that I was involved in over the past few months. So I've been at that lab for 1.5 years. I walked through some of the features of the app and talk about my poster and how later on we did see that there was a statistically significant decrease in perceived stress for the participants in the multi-component program versus those just in the caregiver skills group, but that the other variables did not show a difference between groups. So then I looked at other correlations and at the mediation of rumination between sex and caregiver burdens. And then I was just like, okay, what did I learn? It was really fascinating to follow a clinical study from start to finish. So some of this is a bit out of order because when I joined, we were recruiting for that study, but now we've been working on preparing for another study. So I've not personally been involved with IRB approval, which is approval needed for study from the Internal Review Board, hospital related. But I've been working with Pauline, and she'd been heavily involved in that, so I got to see some of that. I've been creating questionnaires in RoadCap for the new study that we're hoping to start, as well as writing some modules to some of the short write-ups, and translating some of the questionnaires from English to Spanish. And like these modules that I've been working on are in Spanish for our next study. I got to see multiple recruitment methods. So we did a lot of letters, but there was also flyers, waiting room conversations, and talks at community centers. So learning about different methods there. As far as conversing with the participants, I feel like that was probably one of the things where I learned the most. I was initially quite terrified to do these phone screens and talk to the participants, but Paulina, who was sadly not here, but was by my side the whole time. She kept telling me, Kimberly, trust yourself. You can do this. And I decided to trust myself. And I actually really enjoyed doing the phone screens and talking with the participants. So analyzing data with R was also something I really enjoyed and learned how to do. I took an online course through Harvard edX and more training through MGH to work with statistics and data analysis. And so learning how to do all that, and then creating and presenting a poster at the Harvard Psychiatry Research Day. So this is at the Harvard Medical School, was just a really fascinating thing for me, who 4 years ago would never have seen myself there. And just knowing that I was presenting a poster among people with PhDs and these, and I was just like, I don't know what I'm doing here, but I was so grateful for that opportunity. So then here are just some references, and thank you for coming. Do you have a question?